The next speaker, Dr. Omar Shehata, Assistant Lecturer of Radiology, Ain Shams University, MRI in preoperative mapping of endometriosis.
Hello and welcome, my dear professors. My name is Omar Shehata, Assistant Lecturer at Ain Shams University Hospitals. I will talk about a very common topic we encountered in our daily practice at Female Imaging Unit, which is endometriosis. In the next 20 minutes, I'm going to talk about the role of MRI in preoperative mapping. So firstly, what is endometriosis? Endometriosis is a chronic inflammatory disease involving the growth of endometrium-like epithelium and stromal cells outside the uterus. Regarding its prevalence, it is considered one of the most common gynecological diseases found nearly in 8 to 10% of the female general population. More than 80% of the affected patients are of reproductive age period. Females with this disease usually present with pelvic pain, dysmenorrhea, and dyspareunia, all of which can strongly affect the quality of life. It is also closely related to infertility. About the etiology, the exact etiology of endometriosis remains unclear. The most prevalent theory is the retrograde menstruation phenomena. The reflux of endometrial tissue through the fallopian tube by retrograde menstruation results in implantation and growth on the peritoneal surface. Another theories are seen detailed in the image. According to types and classification of endometriosis, it is divided into 3 types. The first type is adnexal endometriosis, which include ovarian endometriosis and tubal endometriosis. The second type is pelvic endometriosis, which includes superficial peritoneal endometriosis and deep infiltrating endometriosis. And the third type is extrapelvic endometriosis. Ovaries are the most frequent site of ectopic endometrial tissue, and the superficial peritoneal endometriosis is the least severe type in presentation. Ultrasonography is the first-line imaging modality for assessment of pelvic endometriosis because of its easy accessibility, low degree of invasiveness, and cost-effectiveness. Nevertheless, it is constrained by limitations such as limited field of view and operator dependence, as well as poor resolution of the transabdominal ultrasound in case of failure to perform a transvaginal ultrasound, such as in virgin patient or severe pelvic pain. This is an example for transvaginal ultrasound shown the classic appearance of endometrioma as an avascular unilocular cyst containing low-level homogeneous ground glass like internal echoes as a result of hemorrhagic debris. MRI is recognized as a valuable tool for diagnosis and pre-surgical planning and mapping of the pelvis. Although it is expensive and time-consuming, MRI has advantage that ultrasound does not. It is more objective, and the image can cover a large field of view with multiple directions. Due to excellent contrast resolution, the combination of several MRI sequences can provide detailed information about the location and histological characteristics of endometriosis. The European Society of Urogenital Radiology provides recommendations on the optimal MRI protocol and the guidelines, which include T2 weighted image, axial and sagittal and coronal sequences, T1 weighted image with and without fat sat suppression. Regarding contrast enhancing T1 and diffusion weighted image and susceptibility weighted image are not recommended for the evaluation of the classic ovarian endometriosis and deep infiltrating endometriosis unless endometriosis associated ovarian malignancy is suspected. Also, oblique axial T2 weighted image is useful for assessing uterosacral endometriosis, which is a type of deep infiltrating endometriosis. Firstly, we start with the most common type of endometriosis, which is ovarian endometriosis. The term ovarian endometrioma should be used if the cyst is larger than 1 centimeter, while if it was less than 1 centimeter, it is called microendometrioma. And in this case, the ovarian endometrioma demonstrates high signal intensity with no change in intensity at fat sat sequence and low signal intensity at T2 weighted images. Is typically described as a shading. Another common finding in MRI is T2 dark spot, which appear as discrete, well-defined, markedly hypointense foci within the cyst on T2. The second type of adnexal endometriosis is tubal, seen in this case where endometrioma shown at a yellow arrow as a high T1 and low T2 signal intensity, while the hydrosalpinx show at a red arrow as a low T1 and high T2, and lastly blue arrow show as an iso-intense T1 and hypo-intense T2, which was likely a leiomyoma. Information by gynecologist at the MRI report for appropriate pelvic mapping requiring reporting the maximal endometrioma diameter to report the number of lesions, whether it's unilateral or bilateral, presence of any associated dilated tube, and lastly, residual ovarian parenchyma and size and number of the follicles. One of the trickiest forms of ovarian endometrioma is desvisualization, which happen approximately to 12% in pregnant patients with endometriotic cyst. Similar pathological changes might also be observed in premenopausal patients treated with oral contraceptive pills and anti-progesterone steroids. As seen in this case, which show decidual change of an ovarian endometriotic cyst at 16 weeks of gestational female, image A show small ovarian endometriotic cyst showing shading at sagittal T2 image and hyperintensity at image A, back to image and hyperintensity at image B, back to image A. The cyst is observed just behind a pregnant uterus in the middle of endometriotic cyst. Decidual changes are observed here. As irregularly thickened soft tissue show hyperintensity on T2 and the hypointensity at T1 with no contrast enhancement at image C or no diffusion restriction at image D. So in this case, differential diagnosis with autonomous growth of cancers should be suspected. We can differentiate between both by the height of the mural nodule, which should be less than 11 millimeter in case of endometriotic cyst of desvisualization, and also higher ADC values and high signal intensity of intracystic fluid on T1. One of the complications of ovarian endometrioma is the risk of malignant transformation. Although it's rare, the relative risk of developing ovarian cancer is up to 4.2 times greater in female with endometriosis than in the general population. The most frequent histological types of endometriosis-associated ovarian carcinoma are endometrioid adenocarcinoma and the clear cell carcinoma. Early detection of malignant transformation is important because clear cell carcinoma is chemotherapy resistant. The three key MRI findings for endometriosis-associated ovarian carcinoma are: the most sensitive one was emergence of enhanced mural nodule within the ovarian endometriotic cyst. The second key finding was increased tumor size. It was reported that an endometriotic cyst diameter of more than or equal 9 centimeter, or if the solid mural nodule is larger than 3 centimeter in thickness, is an independent predictive factor for the future development of ovarian cancer. The last finding is lack of T2 shading. As in this case, at image B, show high intensity signal at T1 weighted image. Image C showing persistently mild increase in fluid intensity, although T2 dark spots are still visible at the bottom of the cyst as sagittal T2 weighted image. Image D show nodule showing post-contrast enhancement, and image E show diffusion restriction. The last image shows surgery has been performed. The mass has been pathologically resected. The mass has been resected and pathologically diagnosed as clear cell carcinoma. The second type of endometriosis is superficial pelvic endometriosis. It is defined as endometriosis with less than 5 millimeter of peritoneal invasion. Its burden is underestimated by MRI. In superficial endometriosis, also known as Samson syndrome, superficial plaques are scattered across the peritoneum, ovaries, and uterine ligaments. At laparoscopy, these implants may be seen as superficial powder burn or gunshot lesions. Regarding MRI appearance, in this case, T1 hyperintense foci on serosal surface of the uterus, as described here, as shown here. Deep infiltrating endometriosis, defined as endometriosis infiltrating the peritoneum to a depth more than 5 millimeter in thickness. Two morphological subtypes often seen. The first one is active glandular morphology, which appear as T1 hyperintense, T1 hyperintense, and T2 hypointense hemorrhagic glandular tissue with or without T1 hypointense and T2 hyperintense cyst. The second one is chronic stromal fibrotic morphology, which appear in MRI as T1 and T2 hypointense linear or stellate shape, like here, that may cause tethering and obliteration of spaces, resulting in fibrotic scarring across a peritoneal or retroperitoneal space, bringing adjacent organs into fixed contact with one another. It is recommended when a radiologist evaluates and reported an MRI for endometriosis, the pelvis should be divided into compartments as previously suggested by different international and national societies. The European Society of Urogenital Radiology agreed on the following compartments: anterior, posterior, and medial and lateral, and also extrapelvic. Regarding the anterior and medial and posterior compartment, are defined by two figurative straight horizontal lines, with anterior line passing anterior to the cervix or vagina and posterior line passing anterior to the rectum, while the lateral compartment are medially delineated by two figures, curved ventrodorsally, as shown here in the image. First, we start talking about the center anterior compartment involving the bladder. Information needed by surgeons for appropriate MRI mapping that the nodule should be measured at maximum dimensions, description of the lateralization of the lesion as midline or right-sided or left-sided, as well as the distance to the urethral orifice should be requested. As shown in this case, presented with bladder endometriosis with dysuria, seen in coronal and sagittal T2 image, reveal a well-defined low signal intensity nodule in the bladder projecting into the lumen. The nodule exhibit heterogeneous content due to small cystic areas indicative of glandular component. The second component of the central anterior compartment is the proximal round ligament. Information needed by surgeons in the MRI mapping is the ligament thickness and the measurement of endometriotic nodule, showing either glandular or stromal fibrotic morphology. As illustrated in this case, affecting the proximal third of right round ligament in a woman with chronic pelvic pain, shown in sagittal and axial coronal and axial T2 MR image, demonstrate low signal intensity nodular thickening of the round ligament and its uterine insertion site. The second compartment is the mediocentral compartment, which is the most frequently involved by endometriotic deposit. The compartment is further subdivided into three smaller compartments. The first one is torus uterinus and the proximal uterosacral ligament. The torus uterinus corresponds to the site of uterosacral ligament diffusion to the cervix, forming a semicircular like here. By MRI, uterosacral ligament thickness is normal if it's less than or equal to 3 mm. Any increase in thickness or nodule is visible, or if a T1 bright spot is detected, abnormality is usually considered. Information needed by surgeons in MRI is description of the site, whether proximal or distal. The infiltration of the mesorectum is also an important element to report, especially if the infiltration extends laterally, as this makes the surgery more complex. The axial T2 MR image show proximal uterosacral ligament thickening, as shown here, with low signal intensity and irregular margins, known as archiform pattern. While in image B, the coronal T2 weighted image demonstrate asymmetric bilateral thickening of the proximal third of the uterosacral ligament. The second one of the mediocentral compartment is the retrouterine space, or pouch of Douglas, which is suspected when there is a partial or complete obliteration of the retrouterine space, with or without a suspended or lateralized fluid collection. As illustrated in this case, which show bilateral ovarian endometriosis and kissing ovaries with severe pelvic pain. Image A show axial T2 shading within the bilateral endometriosis. The ovaries are medially displaced in the retrouterine region. Image B show sagittal T2 shading and the fluid level within the left endometrioma. There is also a low signal intensity noted here, thickening of the peritoneum, of the ovarian fossa, and tethering of the bowel serosa. The ovarian capsule, tethering of the bowel serosa to the ovarian capsule. Image C showing axial T1 fat set with bilateral high signal intensity cysts, likely due to hemorrhagic content. The last subdivision of mediocentral compartment is the posterior vagina and rectovaginal septum, as noted here. Posterior vagina is suspected if there is partial replacement of the posterior vaginal wall, posterior vaginal fornix on T2 image, with a hypointense thickening or a mass behind the inferior posterior wall of the cervix. Rectovaginal septum is suspected when the rectovaginal space, which is a retroperitoneal location, here, which is a retroperitoneal location corresponding to the space between the vagina, including the posterior vaginal wall, and the anterior wall of mid and lower rectum below the peritoneal reflection of the Douglas pouch. The term rectovaginal septum deposit must be used for the peritoneal or retroperitoneal below the Douglas pouch nodules only. Information needed by surgeons in MRI is the length of nodules and its thickness, as well as the distance to the anal verge should be mentioned. As in this case, in the first two upper image, show posterior vaginal wall in the female with deep dyspareunia. The axial T2 MRI image show nodular thickening occupying the posterior vaginal fornix. The axial T1 fat-sat MRI show hyperintensity foci within the nodule. The lower images show another case of endometriosis affecting the rectovaginal septum in a female with dyspareunia. The sagittal and axial T2 MRI image demonstrate nodular thickening of low signal intensity of the rectovaginal septum associated with adhesion to the anterior rectal wall. The last central compartment is the posterior compartment, including rectum and rectosigmoid junction. Information needed by surgeons for appropriate mapping to report rectal or rectosigmoid nodule needs to include the location, whether it's lower, middle, or upper rectum, or at the rectosigmoid junction, the number of the nodules, longitudinal extension, distance to the anal verge, and associated rectal wall thickening. As illustrated in this case, that show rectal and sigmoid endometriosis. Image A show sagittal T2 with a mass illicit low signal intensity affecting the anterior wall of the rectum with a typical mushroom cap pattern appearance. Image B and C show axial and coronal T2 speculated endometriosis, endometriotic nodule also infiltrate the rectovaginal septum and the posterior vaginal wall. The distance between the inferior margin of the rectal nodule and the anal verge must be measured as represented by the dashed line on sagittal T2 weighted MRI image. Lateral compartments are located at the right and left of the pelvis and contain anteriorly the distal portion of the round ligament, medially the mediolateral parametrium including the ureter and the uterine artery, and posteriorly the posterolateral parametrium including distal uterosacral ligament and sacrolectal septum. Information needed by the surgeon at the MRI report from distal round ligament. The nodule can be near a femoral nerve and external iliac vessels, and these elements must be reported. Information needed by surgeons at MRI report for mediolateral parametrium is a description of the parametrial involvement, as the risk of hypogastric plexus injury is important, and the patient should be informed of the risk of the adenovidusuria. Moreover, the extension of the uterine artery should also be evaluated to predict the risk of hemorrhagic complication. Information needed by the surgeons at MRI report for the posterolateral parametrium that the distance or extension to the iliococcygeus muscle of the levator ani was important to describe. Lastly, we are going to talk about the least common site for endometriosis, which is extrapelvic endometriosis. For abdominal wall endometriosis, the urgent sites are the inguinal umbilical regions. Such patients are often admitted to the hospital with cyclic abdominal pain and therefore referred to dermatology and not to gynecology. In addition, the influence factors such as prior surgery, including cesarean section and hysterectomy, are well known as seen of the left image. On the ultrasound, lesion show hypoechoic rounded or oval nodule with well or ill-defined borders and the hyperechoic rim. MRI show a hypointense solid on T2 weighted image with hyperintense internal hemorrhagic cyst or hyperintense hemorrhagic cyst on T1 weighted image. Another site for extrapelvic endometriosis is a thoracic type, which is classically presented by catamenial pneumothorax as presented in this case, which show a pneumothorax with a high dense effusion. During the operation, a small defect is observed in the diaphragm. It was thought to be the migration path of the endometrial tissue from the peritoneal cavity to the pleural cavity. On the basis of pathological examination, endometriosis was diagnosed from the tissue around a small defect of the diaphragm. Lastly, this is a report template for endometriosis advised by European Society of Urogenital Radiology to report an endometriotic case. Thank you.
Thanks, Dr. Omar, for this nice presentation. Any question?